what I want to share with you are some tips and tricks on how to navigate these patients, some tools of the trade, and also just want to review with you the workup of patients with palpitations, because since we're seeing this so frequently, it's a good idea to brush up on some of the basics. So let's get started. Now, what I just want to instill into you is that the best way to approach any chief complaint, okay, whether you're dealing with abdominal pain, chest pain, shortness of breath, it's always the worst things first. That way you don't get burned, right? And how do we think about the worst things first? Well, with palpitations specifically, we're worried about potentially brugadas, right? Oh, hey, what's up going on, Sarah? Hey, Aubrey, hey, Daph, and hey, Shayna. So we're thinking about brugadas. We're thinking about potential hypertrophic obstructive cardiomyopathy, because those are two things that kill young people that we don't want to miss. And also, in case you're wondering, we will be covering a few of these things in our challenge starting January 3rd. But it's, if you already know what these are, then you're already looking for them, right? And you're also honing in on the QT interval, because if you have a long QT, patients potentially could have torsades. Hey, Andrea, you made it. What's up, sister? So then the other thing we're scanning for, because this is also dangerous, would be a short PR interval or potentially a delta wave, because those two things mean they could have Wolff-Parkinson's White. We're also looking for pauses, and of course, we're looking for SVT, and we're looking for tachycardia. And I will tell you, these are the dangerous things. Of course, these are the dangerous things, but we are also thinking about the other things. Now, what is it most likely going to be right now with people so anxious, with patients that have COVID or have had COVID? We're seeing a lot of PVCs, okay? Seeing a ton of PVCs or PACs. And I just want to take a second to talk about that real quick, because PVCs can be dangerous, and you need to quantify how many PVCs are having in a 24-hour period, because the danger of too many PVCs is that patients can go into heart failure. So we definitely need to use our tools. We need to use things like Holter monitors. And if you're in family medicine and you don't have Holters, you want to refer the patient, right? The worst thing we can do is like say, oh, you're fine. You're totally fine. It's just anxiety. That's the worst thing we can do. Okay. So that's the list of things I look for each and every time. That's part of my 10-step system, the chief complaint-based approach. And if you don't know my 10-step system, that's okay. We'll be covering that again on January 3rd live for you when we start our 5-day challenge. But in the meantime, let's talk about a case. Now, of course, this is not our old patient's face, but this is a case of a 25-year-old male who had palpitations. Now, I just got to do a little commercial really quick for doorway diagnosis. And what doorway diagnosis means is that when you go in and you see a patient, what do you think about? Okay. Oh, hey, Susanna, how's it going? Hola. So what do you think about, right? Are you looking at their skin signs? Are you looking at their breathing? Are you looking at the way they're sitting? Are you looking at the way they engage with you? Now, this gentleman's looking you straight in the eye. He's leaned back, fairly comfortable. He doesn't look to be in any distress. So that's reassuring. Now, luckily, he already has an IV, which is fantastic, right? In case we need to give him anything. But what I want to know, first and foremost, obviously his vital signs and history, but I also want to see an EKG. So here is his EKG. Oh, wait a minute. That's kind of strange, because if you look at this, it's kind of fast, right? And fast in a young person is concerning. So I'm just going to orient you in case you might be new, right, to reading EKGs. I'm going to orient you real quick to a couple things that you need to know. Now, here's your 12 leads, right? And this here at the very bottom is your rhythm strip. This is V1 being pulled out. This is what you're going to use when you decide what the rhythm is, because we have to make a decision. This gentleman's going fast, so we need to know, first things first, if he's fast, we need to ask ourselves 3 questions, right? Is it regular or irregular? Okay, and you're going to draw that to help you see if it's regular or irregular. So type in the chat, is this regular or irregular? Regular or irregular, okay? Step number 2 is we need to know if it's narrow or wide, right? Because narrow comes from the top, wide comes from the bottom. And this patient has a QRS duration of 64. So you can see it's pretty skinny. We're happy with that. Hey, Molly, what's going on? Melissa Mainville in the house. What's up, girly? So Melissa and Andrea, you guys say it's irregular, and I agree. Totally, 100%. And there's a trick. If you can't see this with your naked eye, you take and you draw it out so that you can see it. You can take a paper and pen and do it. No big deal, right? We always have paper and pen no matter where we are. So we have a fast, irregular rhythm that is narrow. So now we know it's coming from the top of the heart. So then the last thing we got to ask ourselves, is there a P wave? Okay. Now, if you scan the EKG, you know to look right in front of the QRS, and there's really not a definitive P. Some people will say, oh, maybe that's a P right there. Maybe that's a P. I don't know. Is that a P? Is that a P? If you have to squint and you have to think, if there's a P wave, it's probably not. Okay, that's rule number one. But then you kind of are left with, you have a tachycardic, irregular patient that's narrow complex. So this is indeed AFib with RVR. How do we know it's RVR, rapid ventricular response? Because it's over what number? So type in the chat, what number is it over to say that they're AFib with RVR, and they're over what number? What makes them the rapid ventricular response part? Okay. So while you're thinking about that, the other little piece of info that is helpful is that he has a star in his PR interval. Good, Danielle. Yes, 100. So he has a star in his PR interval, which means there is no P, which is also helpful. And Danielle also said over 100, and that is true. Anything over 100 is technically rapid ventricular response. So let me ask you guys a question. Type in the chat for me. Why does a young guy have AFib with RVR? What are some differentials? What are some possibilities? What are the potentials for why does he have AFib with RVR? So when you think about some differentials, we wonder, well, he's young. Does he potentially have holiday heart? Does he potentially have heart failure? Does he potentially have myocarditis from the COVID that he recently had? Does he have heart failure, right? All these things come to mind. But yes, Daisy is right. It's irregular. And yes, Jessica Lyons with energy drinks. Love where you're going with that. And Shayna, absolutely love where you're going with that with thyroid. You guys are rocking it. And Natalia says UTOH and COPD. And Melissa says, is he septic? Oh my gosh, these are all really good. Could he have congenital heart disease? Could he have OSA? So as you can see, right, we have a ton of experts here that are like on fire with the answers, and they're all right. They're all right. We consider all of those things, okay? Daisy also wants to know, does he potentially do cocaine? So we would absolutely get an EU-tox, okay? Unfortunately, EU-toxes don't pick up energy drinks, but we would be able to rule that out. If he had obstructive sleep apnea, that's also something we could see if we admitted him, potentially. We could do an ETOH level in Natalia. We could see that. We could ask about his meds, his history, and we could get a TSH. I would absolutely do that, okay? And so he ended up having AFib with RVR, and it ended up that his thyroid was just off the charts. So whoever said that, that was Shayna. Nice job, Shayna. You solved the case. Although everybody with your answers were correct differentials. Okay, so he got really unstable, so they cardioverted him. The other thing I would do when the patient gets cardioverted, that I would go and just make sure, I would go over here and I would scrutinize really carefully. I would scrutinize the beginning of the QRS. What am I scrutinizing this for? What am I looking for? Now that he's slowed down, it's easier for me to see. What am I looking for and what am I worried about? What am I looking for and what are we worried about? Okay, so I'm not seeing it, but I'm looking for it. I'm looking for a short PR interval. And I'm also looking right here for a delta. Again, Shayna Lorraine, you are all over it, sister. And that is exactly right. We're looking for deltas. Yes, Danielle, absolutely. And we don't see, and also Daisy says, look for the QTs. I like that. We absolutely would, but we're not seeing any delta waves. Good, Melissa Mainville, okay? We're looking for it, but we're not finding it. Okay, so we already had our reason. The thyroid was the etiology, so we need to fix the thyroid. So now we know why. But let's do another case because this is always fun. This is case number 2. Case number 2, okay? And he's 21 and he has palpitations as well, okay? And, don't read diagnosis. This is not a real patient's face, by the way. But don't read diagnosis if this was a patient. And you look at him, I'd be like, okay, skin signs, looking pretty good. He looks a little underweight. So I would be worried and concerned about stimulants. I would ask about it. I would test for it. Hey, Tommy, what's going on? Tommy's in the house. Tommy just brought 100 of his friends today to our group. Thank you for that, Tommy. And so he's already got an IV in. They're probably going to give this guy some fluids. He's got some palpitations. So we're going to think about our worst things first. And we're going to go scrutinize the EKG. Okay. Now, looking at him also on the exam, I'd be looking at his mucous membranes. I'd be asking about any volume loss, any nausea, vomiting, diarrhea. I'd be looking for any nystagmus, potentially, any nystagmus or any goiter. All those things would be helpful. And of course, we're going to get an EKG. So this is his EKG, and he's got a fast heart rate. So he's got a heart rate of 158. And I'll tell you what, even though patients get nervous right now seeing us, they're not usually nervous enough to go to 158. Hey, what's up, Lisa? Oh my gosh, Lisa's in the house. What's up, girly? So family history. Daisy wants to know about family history. Tell us more about that, Daisy. What specifically would we ask him? What question about his family history? The next thing we got to do is we got to look here. Is there a PR interval? There is. That's reassuring. And a heart rate of 158. I'm going to be thinking about volume loss. Tell me some differentials that you guys are thinking about. Okay, because he looked pretty good, right? He looked pretty good. So what should we be thinking about with a heart rate of 158? We want to get some blood work, right? I hope they are too, Lisa. I hope they are learning. We want to get some labs. We want to get a CBC, looking for anemia. We want to get a CMP, looking at his kidney function, making sure he's not in renal failure. Daisy wants to know if he has death in an early age family member. I like that. I like that. I like that with all the patients, actually, because sometimes you can uncover some pretty big pearls that way. And especially with coronary artery disease, right? We want to know if it came on early. So it's fast, right? And, the big question is it regular or irregular? So fast, regular or irregular. Ooh, eating disorder. Shayna. Yeah, on fire. I totally agree. I would think about that too. Ooh, Desi wants a mag. A mag is never a bad idea, especially with palpitations. Okay, so is it regular or irregular? Well, it looks pretty regular to me. So we have a regular tachycardic patient. Okay, Shayna says regular. And then the question becomes, do we think it is potentially SVT? Could it be SVT? Or could it be sinus? Do you see P waves? And then the other question that would potentially come up is it also, the worst thing we have to worry about is a 2-to-1 atrial flutter. Fever. Good question. Good question. I would ask that as well, right? Is there fever? And so we got to think about all the things. And so this guy did turn out to be a sinus tach. We were worried about 2-to-1 atrial flutter, but he did turn out to be a sinus tach. He did have some volume loss. We would also get a thyroid. We would also get a urine. And if we were concerned, we would also get a drug screen as well. But this patient turned out to be just sinus tach. They can go up to 158 if they do go this high, though, and especially if they look great and no etiology, then we would absolutely be concerned about 2-to-1 atrial flutter, because if we miss that, then we could potentially be leaving the patient unanticoagulated. So case number 3 is this young female. This is not a real person, so don't worry, but it's a 26-year-old female with palpitations. So looking at her, one thing I look for right away, I'm looking at her neck. I'm always scrutinizing the neck. I want to know, is there thyromegaly? I'm looking at her skin signs. I'm looking at her jaundice. I'm looking for her, icterus and her sclera. I'm looking at her belly distended. I'm looking for JVD. I'm just looking at her overall. She's also kind of on the thin side. So, if she has palpitations, I'm going to ask about energy drinks. I'm going to ask about any thyroid problems. And of course, we're going to do what we always do, which is an EKG. So this one is kind of a slam dunk. And I'm just going to tell you that we're going to be covering the 10-step system in the 5-day challenge we're going to do on January 3rd. But in the meantime, and anxiety, that's another good one. Yeah, Daisy. But remembering that even though we think anxiety and it's honor differential, we don't rule anyone out to just anxiety until it's not something else. Okay. And I'm going to just point out a couple things, because in your 10-step system and drug abuse, good one, Daisy, we would be thinking about that one for sure. In our 10-step, one of the things we look for is rate. The rate's too slow. Okay. Now, could this be that maybe she is athletic? Could that be? Potentially it could, right? Could it be that, she's just really efficient? It could be. Are we worried about a heart rate of 50 in her? No, we're really not, right? She looks good. You can tell she is kind of athletic. So 50, I'm not worried. So then I'm looking for the intervals. Okay. So my 10-step, which I'll be sharing with you, if you've gone through this before, but it's looking at the rate rhythm intervals. The intervals are the numbers that are up here on the EKG. These numbers are really where there's a lot of clues to be found. One of the clues for this EKG in particular is right here. The PR interval is 88 milliseconds. What do you guys have to say about that PR interval? What do you have to say? Oh, so Daisy says, look for her medications. What specifically, Daisy, are you looking for? Give me more on that. Samantha says delta wave. I agree. Samantha, if you look right here, there is a beautiful delta wave. And we also had Shayna. Shayna says, is there a P wave? So interestingly enough, Shayna, this is one other thing that I wanted to kind of point out to you guys. So it's kind of hard to see. Melissa's like, is she on beta blockers? Good one. Yep, good one. So is there a P wave? You can see over in V5 and V4 and V6, you don't really see a P wave. Daisy, beta blockers, I love it. I love it, okay? But if you go over here in AVL, you can see a P wave right here. If you go over here in lead 2, you can see a P wave. It's actually inverted. Yes, calcium channel blockers too, Samantha, totally agree. And you can see right here, there's P wave, inverted, okay? So there's inverted P waves that are really close to the QRSs, and that is another sign that you're dealing with a junctional rhythm, okay? So you have a junctional rhythm because the P wave is present, but it's inverted, and the heart rate is consistent with junctional as well, and you had an underlying Wolff-Parkinson's-White because, yes, Daisy junctional, good job. And you can see that, yes, this was an underlying Wolff-Parkinson's-White. Ooh, looking for antipsychotics as well, always a good idea. But here's the thing, guys, you can see the delta wave in almost all the leads, which is very interesting because you can't always. But when you start looking for it, it becomes fairly evident. Okay, so this was a Wolff-Parkinson's-White. That's why she was having palpitations. So type in the chat, what do we need to do to her? What do we need to do to her to fix her? Okay, what do we need to do to her, fix her? And now we're going to talk a little bit about things to look for on the exam. So what do we look for on a patient on the exam? I kind of touched on it a little bit already, but let's take this guy, not a real patient. Let me just do the caveat, but tell me some things, okay? Tell me some things in the chat that an ICD, okay, actually, Wolff-Parkinson's-White patients don't need ICD. You may be asking, probably talking about this guy. Jessica, yes, they need Wolff-Parkinson's-White ablation. So Daisy says refer to cardiology. They do an EP study and then they ablate the Wolff-Parkinson's-White. So the pathway is gone and no longer causes problems. They're really cool procedure because patients actually get better, which is neat. Neat. Okay, so pacemakers at a rate of 50, they probably don't need a pacemaker yet. They have to be really slow to need a pacemaker. So Shayna, ablation, and Daisy EP study. Yep, good job, you guys. Okay, so now let's transition over to the exam, because the exam is honestly often overlooked. And I'm so excited because you guys are the first to hear this, but in January, during the 5-day EKG challenge that we're going to do, we're going to have a special guest who is coming on. And he's going to talk about the exam, and he thinks that the exam is a lost art. So he's going to talk a little bit about that. But he actually, let me see what I did with it. I had his book's right here. So he wrote this book. I don't know if any of you have this book, but the guy who wrote it, Michael Chisner, he's going to be one of our guest lecturers. So I'm really excited about that, because but literally you can see this book. I used it during PA school when I was like learning about cardiology. It's so old. I've had it since 2004. So don't judge me for having a ratty covered book, but like, it's such a good book. So I got him to come speak, and I'm super thrilled. And you're gonna get to learn along with us. Yeah, isn't that exciting, you guys? Yay! Natalia has it. So does Kiki. Right? Hey, Kiki, it's been a while since I've seen you, sister. And cards for revelation. Okay, so let's go back to the exam. I just couldn't keep I can't keep secrets from you guys. I had to tell you. So the exam, what do we look for? Yeah, Tabitha, you should totally come. Totally come. They're all recorded though if you miss them. So on the exam, what am I looking for in a patient with palpitations? So I'm looking specifically right here. What am I looking for? What am I looking for right here on the eyes? What am I looking for in the actual eyeball itself? What am I looking for on the lids? What am I looking for? There's two things on the eyeball I'm looking for. And then tell me what you're looking for here. And then tell me what you're looking for here. Nystagmus for sure. I like it. And icterus, Tabitha. Yes, those are really good. One more thing in the actual eyeball itself. So there's actually three. The other thing would be, think eyeballs, bulgy eyeballs. What are bulgy eyeballs called? And JVP, I like it, Daisy. I like it. Anemia, dehydration, goiter. Yes, all those things for sure. Goiter on the neck. Yep. And let's think about what we would see potentially on the face. And look, he's drinking some alcohol, which we know just by looking at him and the fact that he's drinking alcohol, we're worried about potential. We're worried about him going into AFib, right? Okay, you guys got it. Exophthalmos. Nice. Samantha says, I want a mag. Totally agree. And Sarah said, apoptosis. Okay, so that's what we were talking about with the eyelids, right? Are the eyelids sagging? If they are, we're worried that they could have underlying sleep apnea. Okay, and sleep apnea untreated leads to AFib. And so that's the connection. So we're looking at all those things. Oh, tremor is another good one. So you guys did a good job. Okay, so on the exam, but there's a few more things. Okay, also that I add to my exam. I'm looking for fidgety. I'm looking for thin framed, because these things make me think about, do I need to get a TSH, which I'm already going to do, right? I'm thinking about drugs of abuse. I'm thinking about energy drinks. I'm thinking about it, all the eating disorders. Are they obese? I'm thinking sleep apnea. Are they in pain? Thinking about that. And on this guy, while I'm rattling through this, what is this? The cheeks? What are the cheeks a sign of? What are the cheeks a sign of? Good, Daisy. Yes, I'd always be looking for a thrill. Yes. But HENT, you're looking for the mucous membranes. And the bulbous nose is another thing. Now, we can't see noses anymore because of masks, but the bulbous nose is another thing we would look for that would tell us this patient could be drinking a lot of alcohol, potentially, right? We already see he's got two, probably Guinness in his hands. So we already know he's going to be seeing us at cardiology. This is not a real patient, by the way. And he's got an irregular on his cardiovascular exam. So he probably is an AFib already, right? And if he's in AFib, he's probably going to have an elevated CHA2DS2-VASc score, so he shouldn't be drinking. And also, if he hits his head, all the bad things. So going back to extremities, sorry, tangent, looking for edema, also looking for clubbing, and then the flesh skin. So what is the cheeks? Tell me about the cheeks, you guys. Nobody chimed in on the cheeks. What does the cheeks tell us? Okay, Tabitha says butterfly rash or broken veins. Absolutely. So potentially butterfly rash, but the broken little blood vessels often happen in patients who do a lot of what? Patients who do a lot of what? You guys are all right, by the way. All right. Patients who do a lot of ETOH, right? ETOH. Okay, now this is another really quick one just to show you that 55-year-old male. Telangiectasia, yes, Sarah, strong work, strong work. Okay, now, you guys, I wanted to quiz you and I want to see if you know what we're looking at here, okay? So, good job, Andrea, yes. And Tavitha, spider angiomas, okay, yep, lots of drinking. So, what is the CKG? What is the rhythm on the CKG? This patient has palpitations. They're 55. What is the rhythm? Okay, so just to kind of show you where we would go look for that, we look for in two places. I always look here. That tells me if I have a P wave. And I always look at the rhythm strip pulled out, the long lead. So for example, this is V1 pulled out for us right here, right? Daisy said she thinks it's AFib. So there's two clues, right? It's irregularly irregular and everybody's getting it. Yes, this is AFib, okay? But it's AFib with, what's the with part? You guys all got it. C. Adams and Danielle, nice, you guys. And it's irregular. So it's AFib with, oh, we have someone on Zoom. Oh, hey, Tommy, you're on Zoom with us. Nice to see you. Yeah, so it's AFib with RVR, Danielle. Nice. Danielle for the save down there. Thank you. So AFib with RVR, right? Because it's over 100. And the key to that was that there's no P wave and that there's a star in the asterisks. Okay, so let's talk a little bit about the toys and then we're going to wrap it on up. And hopefully this has been fun for you guys. So what kind of toys do we use in cardiology? And specifically toys that you can potentially use as well. So I break it down into two categories: things the insurance covers, which we love because the patients are more willing to do the tests, right? And things that are included on the insurance plan are things like Holter monitors, right? And a lot of people call these halters. They're actually Holters. And they're monitors that go on with a lot of wires. They're usually 24 to 48 hours. And then you graduate from that to an event monitor, which lasts anywhere from a month to 30 days, usually a sticky patch that goes on you like this, and a lot easier tolerated. But a lot of patients do end up having some allergic reaction to the adhesive. Just know that there is a little bit of adhesive that they have that is hypoallergenic. So you can get a patient that. And then if they do find anything on the device, Holter or event, if they find something that is a pacemaker, this is what they look like, right? Here's a pacemaker. They're getting smaller and smaller. And these are basically all the toys that we have in cardiology. Now, I don't think you can probably order most of these from family, but then we kind of get into a situation sometimes. Yeah, Daisy says no fun. So sometimes we get into a situation where a patient has, and this is where things get dicey, okay? Patients had a Holter. We didn't find anything significant, maybe a couple PACs. And the patient's like, I still am symptomatic. Also, you didn't catch anything on my thing. I didn't have the symptoms. And so Daisy also said the loop recorder. That's another thing that can go right here, actually. The loop recorder would go right here. I have one, actually, Daisy. Thanks for reminding me. I want to show you guys. This is the loop recorder. It's so tiny. It's like the size of a paperclip. This is the Medtronic loop recorder. But literally this thing kind of goes from when you stop the 1 week, before you need a pacemaker, if you need more data, this is where this comes in right here. And this actually sits in a patient's chest and can give you 3 years of data, 3 years of battery life. Tells you about pauses, tells you about all the things, right? Pauses and tachyarrhythmias and AFib especially, which is a lot of times what we use it for. So here's the thing. So if your patient has symptoms and they don't get caught, what we have to do is we tell the patient, well, we can't get anything else covered by the insurance. They won't do it. So we'll sometimes have to go to the things that insurance doesn't cover. So for example, an iWatch can be utilized. An iWatch is pretty pricey though. The low end model is about $399. From what I last checked, it could have changed. And rhythm changes. Yeah, Daisy, absolutely. But the AFib, here's one thing that people don't know. And this is kind of makes me mad. So this watch that is sold, right, is sold under, oh, it's going to detect your AFib, it's going to detect your falls, but you actually have to turn that on. Unless you're over 55, then it automatically is on, okay? And for AFib, you actually have to set it up in the beginning and you have to say you don't have AFib because then it won't want to monitor you anymore for AFib, right? It's looking for it. So you can still get strips of it, but you have to know those two things. And also you have to teach the patient how to do these things. It takes a little bit of time, but I think it's worth it, right? Because sometimes people, they can't get the data we needed on the stuff the insurance covered. So Angela says cardia, I totally agree. And that's what this is here. And that's what we're giving away tonight, by the way, for anybody who's live, you have a chance to win one. So this is what it looks like. Here it is. You can see this is the screen when you're actually getting a recording, okay? Cardia is great. C. Adam says, I had a patient today with frequent PVCs. Yeah, totally. The bonus about the Cardia is that this little plate can actually go in their purse or in their pocket or wherever they want. I tell patients to stick it to the back of their phone, super handy. And I really love this technology because it gives me a really wonderful strip. And the great thing is they're a little bit cheaper. And right now they're actually, I know they're having a sale, I think till the end of the year, they're having like some Black Friday thing. So I think it's like under 75 right now on Amazon for these, which is kind of a really good deal. They're usually, I think, 99 for just this, the plate that looks like this, that gives you just the one lead. But you can tell a lot of things from that. You can tell, you know, if they're having AFib, you can catch PVCs. And the great thing that I do with these is I'll be like, okay, cool. We didn't catch anything. Go home, get me some strips, bring them back. Now the patients can have an option to send the strip up to the cloud for someone to read it. They have to pay for that. But you can have them bring it into your office. They can also download it as a PDF and upload it to MyChart. So there's a lot of really cool technology out there. So Tommy says, my sister has one, and when she goes into AFib with RVR, she calls her MD. Yeah, it's like super helpful. So patients that you know, can also use it for AFib management. So I wanted to take a second and show you what it actually looks like. I have one right here, and one of you lucky people is going to be winning one. We'll be mailing it out to you. So this is the box. This is what it comes in, right? Comes in this little box, and you've got, you can see the plate. Yeah, they call back in 15 minutes or less if you have AFib and you send it up to the cloud. I know it's really fast response, right? So this is what it looks like, right? And I think this is super handy for even my tech challenge patients that don't really know tech, because literally this is what you do. And I even sometimes tell them, like, bring it to the office. I'll just help you set it up real quick if they're like super tech challenged. But I mean, it's pretty easy. So you literally slide it out of the box. And this is why I feel safe to do it in the office too, because it's like super fast. There's an instruction manual. You don't need that. You just take it. And I'm like, yeah, don't need it. Half the battle is getting the instruction manual out of the way. Okay. Then here it is. It comes just this nice little plate. They have to download the app on their phone. It's called KARDA. It's a free app. And then they just pluck the plate out like that. Then they have the plate. Okay. So the key they have to remember is that when they do their strip, they have to open it on their phone, right? They have to open the Cardia app. It'll say collect recording. And then they just have to put their 2 fingers of each hand and get a good connection for 30 seconds. That's it. That's it. And they have to actually hold still. Even better, if you lay it down on a table, you can get a better connection, but you just can't be near anything electronic like a heating blanket or like your laptop computer, because it'll detect interference. So this is the Cardia. I love them so much. And they're on Amazon. The app's free and it's super easy. So this is one of the tools that I use in the practice. And this is my little demo one that I keep in my bag, and I can show patients, because I have an Apple Watch and this, but I can show them this really quickly. And I'm like, oh yeah, you can get on Amazon. Here you go. Comes to you in like 2 days and you can start using it.